Okay, so we'll get started today's session. Some questions. When is reverse pull headgear typically used? Additionally, how does headgear affect natural growth during puberty adversely, i.e. sacrificing mandibular growth to pull the maxilla? So reverse pull headgear is mechanics that is external force pull of the maxilla. So headgear typically is either forward pull or reverse pull or retractive in nature. So it basically straps a frame around the head, and its impact is predominantly on the maxilla with an elastic force that pulls either forward or backwards. So typically, reverse pull is used in class 3 relationships where the maxilla is deficient, and we're trying to stimulate forward growth through use of a vector of force that brings the maxilla forwards. So reverse pull masks, normally the most common type is the petite, where there is a pad on the forehead and a pad on the chin. There's a frame that allows the attachment of elastics to an appliance that is placed in the maxillary arch. So typically it's done in conjunction with maxillary expansion because very often class 3 relationships are one where there's insufficient development of the maxilla. It's not only deficient in the AP, but often it's deficient in width. So very often in typical phase 1 orthodontics, it's done prior to puberty. Maxillary growth tends to outpace mandibular growth. Typically, the width of the maxilla slows down after a 7th year. So over 90% of the width is established once the 6-year-old molars come through. So by the time they're socked in at around 7, most of the width is complete. So if it's insufficient in width to marry up with a larger lower arch, then you'll need some form of expansion, and it's usually sutural. So it's usually a fixed appliance, a Hyrax, or some form of bonded to the molar relationships. And a hook is welded to that appliance that can be attached to elastics to the headgear frame. As the growth of the maxilla slows down before it hits puberty, before the child hits puberty, the typical timeline is prior to puberty. In class 3 cases, as early as possible is usually when that is done. When we apply a pull to the maxilla, it has to be reciprocated. There has to be some form of anchorage. And the typical anchorage point is the forehead and the chin. So the thought pattern is we pull the maxilla and we put a retractive force on the chin. And so that counteracts the overgrowing mandible and undergrowing maxilla. Because of the nature of growth, modifying growth, which is what the reverse pull headgear or any form of headgear strives to achieve, is best during the most rapid growth period. And the most rapid growth period of the maxilla is in the first 10 years of life. So ideally, we would like that in the first decade. It tends to be less and less effective as we get older. Typically, the goal is some form of skeletal anchorage. So bonding appliances to the molars provide some form of whole arch pull anchorage. But we do tend to find that it's less effective if you're using the dentition only. So historically, in younger patients, it's done through a bonded appliance to the primary molars and the first molar. And in older patients, sometimes a surgical placed anchorage on the maxilla, like a bollard, allows pull on the maxilla in older patients as well. Theoretically, if you're reciprocating against the forehead and the chin, you're hoping to hold mandibular growth. Does that actually work? It's hard to say, but it's usually not effective in stopping mandibular growth. Mandibular growth through orthodontic or orthopedic approaches tends not to be particularly effective because growth of the maxilla and the mandible are stimulated by different forces. The maxilla, its growth is synchondrotic and is linked tightly to the growth of the head. Typically, true class 3 relationships can sometimes have very short cranial bases, so you don't have as much maxillar growth. Mandibular growth is tied very tightly to the tongue. So a low tongue posture will stimulate mandibular growth at the expense of the maxilla because there's no additional stimuli to the maxilla. Unlike children who have good posture where they rest their teeth together and their tongue on the palate and the floor simultaneously. We can't just rely on posture in class 3 situations because we've got a reverse bite and you've actually got to bring the maxilla into the right kind of class 1 relationship before you can rely on posture to continue on with optimum balance growth. What we have to understand is we have to use the right mechanics and the right pull force for each situation. reverse pull is predominantly focused on the maxilla with a little hint of retractive force on the mandible. So it's focused on class 3 relationships. It has a vector of pull that is forward, but there's also a downward pull because of the way the elastics comes out of the mouth. So in class 3 relationships, a forward and downward pull vector is favorable because a forward and downward pull vector creates a clockwise rotation of the maxilla, which kind of forces the mandible back a little bit in an opening rotation. So the more you open your mouth, the more class 2 you become. So that's one of the adverse effects which can benefit a low angle class 3. If you use reverse pull on a high angle class 3, you'll get an improvement in the maxillary situation. You'll get a reduction of the class 3 relationship, but a high angle class 3 tends to be predominantly downward growing. So it exacerbates the open bite relationship. So reverse pull tends not to be as effective in the class 3 high angle cases if you don't control the vertical component, which is very hard to do unless you combine it with intrusion forces in the molars, or if you're very, very strong on improving posture. There's a strange misguided trend for clinicians to consider using reverse pull on the maxilla in class 2 patients. Given the fact that the vector of pull is forward and down, and the mechanics requires you to have a pressure on the mandible, using reverse pull on anything other than a low angle class 3 tends to be detrimental. You might develop a little bit more forward movement in the maxilla, but you're going to be worsening the class 2 by holding the chin back and driving a clockwise rotation of the jaws. Okay, next question. Why is it more ideal for providers to prefer an early than late orthodontic treatment approach rather than a traditional approach of waiting until age 11 to 15? I would love insight into why treatment during the 11 to 15 age is often considered less ideal for orthopedic correction and facial growth modification. So the most rapid growth occurs in the first decade. The second decade, the growth slows down and the bones start to harden through calcification. So growth modification works best in rapid growth and when the bones are soft and pliable. We tend to find that when you hit the second decade of life, the focus of growth is actually the hardening process, right? So tightening, changing over from more organic component in the bone structure to more inorganic component. And hardening tends to lock the relationship together, which is the whole point of being an adult. You have maximum leverage through stiff bony structure. If you want to affect change in bone, you want to do it when the bone is soft and not when the bone is hard. It's very easy. It's historically in all treatments, it's much easier to make change in the maxilla than the mandible, mostly because mandibular bone is more dense than maxillary bone. It's easier to achieve orthopedic changes in the very young because young bone is less dense and more pliable than older bone. Next question. One of Dr. Hub's patients where you're using upper and lower plates with class 2 elastics. Can you explain why you decided to use class 2 elastics in this case versus focusing more on posture to bring the mandible forward? Is it a treatment protocol you're now using? In this case, you're attracting the upper centrals, but not the laterals. Well, each situation is different. What we do depends on the age, depends on the malocclusion, depends on the circumstances that we're dealing with. So class 2 elastics is used to improve the dental relationship. And if you have a significant discrepancy in the AP, then sometimes closing the mouth isn't enough. Sometimes you got to bring the teeth also into a better relationship. So each scenario, each situation is different. You're taught in postural orthodontics to focus on mild to moderate cases so that you can focus on very basic mechanics of expansion and very basic methods of improving AP relationships through focusing on the posture. The more severe the case, the less successful basic postural orthodontic treatment comes, and the more complex mechanics and complex therapies have to be added in. So if we're going to use class 2 mechanics as well as improving posture as well as expansion, then obviously it's not a mild or moderate case, and it's a more significant or severe case. So when you're dealing with more complex, more significant out of balance situations, you just have to use more things to achieve your goal. Okay, question 4. I understand that over 50% of Chinese descent have skeletal class 3 malocclusion because of short cranial base. Does that mean that all the class 3 malocclusions of this descendant would need reverse pull, including those who are pseudo class 3 that has a short cranial base? So a short cranial base will predispose your growth to more of a class 3 relationship. And Orientals have typically shorter cranial bases than Caucasian people. We have a much higher percentage of class 3 in the malocclusions. Typically, Caucasians will have less than 5% of malocclusions being true class 3s, whereas Orientals may have anywhere between 7 to like 15% of malocclusions being class 3, and that's been attributed to a short cranial base. If you understand the concept of posture, I suspect also that's to do with the language. A lot of Oriental languages require a lower tongue position and pressure from the tip of the tongue on the lower incisors to affect the speech mechanism. So I suspect some of the class 3s are actually related to the language and how the pronunciation of the language requires a lower tongue placement. As far as the mechanics of how to manage them, yeah, if you have a deficient maxilla, you can use reverse pull to help manage the class 3. For sure, because that's the only way you're going to be able to have any impact. So class 3s can be normal size maxilla and an overgrowing mandible, or it can be an insufficient maxilla and a normal mandible. Can also be insufficient maxilla and an overgrowing mandible. So each of those scenarios will give you a estimated chance of success with treatment. Right? So the most successful class 3 corrections are in order of success would be pseudo class 3s because they're not actually skeletal class 3s, they're just dental class 3s. Followed by low angle insufficient maxillas and normal mandibles. Followed by much more difficult when it's a normal size maxilla, but an overgrowing mandible, followed by the most difficult being an insufficient maxilla and an overgrowing mandible. The complexity, of course, increases in multiples when it's a high angle case. Using reverse pull is least effective in high angle class 3s, and it's inappropriate to use reverse pull for pseudo class 3s because both the maxilla and the mandible have a normal relationship. It's just a dental class 3. Next question. How does one determine if the maxilla is deficient? By reference to the frontal bone and any other considerations. So this is where cephalometric analysis comes in, and cephalometrics uses many methods, typically in the Eastman analysis, you're looking at, A point, B point relationships, widths also useful tools to help determine, but you're effectively looking at A point and B point, trying to figure out what that relationship is to SN or the cranial base. So determination of skeletal imbalance is through cephalometric analysis, and there's dozens and dozens of different methods to determine maxilla to mandible relationship, the jaw relationship to the cranial base, both in vertical and in the AP relationships. So skeletal relationships are determined through cephalometrics. And cephalometrics has multiple points of reference in the head and the jaw system. There's a whole science behind how you measure the various points and how to assess the relationship of those various points. How does one know if the child has a short cranial base? Is the cranial base measured by looking at SN value? If so, is there a normal range measurement we can measure against? Yeah, so again, cranial base is effectively the SN, but also basion, right? So it includes those the whole sphenoid. So those are your main reference points, and yes, there's normal ranges. You just need to look up your norms in the cephalometric analysis, and you'll figure that out. But it's all relative to mandibular length and mandibular size as well. So again, cephalometrics, there are accepted norms, and we basically compare the child at hand with the norms that have been generated over the last 100 years of cephalometrics, and we figure it out based on linear and angular measurements. How does one determine if the maxilla is deficient? Yes, so we get measurements. So again, cephalometrics. So these are all basic cephalometric analysis, understanding cephalometrics, how we determine all this. Next question. My husband is a general dentist in a local study club with an older orthodontist. This orthodontist made comments in recent meetings that he is upset with the so-called airway dentist charging $13,000 to expand it. Archers claiming to treat the airway. He said they can just come to me and I'll expand them for less. This same orthodontist has told patients of mine who had originally seen him consult first or later for a second opinion that yes, child is severely crowded or has posterior crossbite, and that the parents are better off putting their money in a savings account now and saving up for orthodontic treatment later when they are older. This orthodontist says it doesn't make any difference in the outcome if they expand early or late. Can you please tell me how you would respond to this claim, and at some point, either myself or my husband will be in a position to debate this issue casually with him and the group. I would love to have any responses nailed down. Also, I appreciate your course where you stress the importance of us not claiming we are airway dentists. My husband responded to him in that meeting, dentists don't treat airways, and he loves that response. So we have to understand what we're driven by and our hopes and expectations and what we're capable of and what we're licensed to do. And we have to understand why historically and even currently, of course, early intervention has not been particularly successful. When we understand these separate but interconnected issues, then we can answer questions through awareness of knowledge and awareness of reality. So in the 20th century, we developed the concept of orthodontics, where we discovered we could predictably move teeth. And in the second half of the 20th century, we discovered that if we use external pull forces or internal mechanics, that we could make changes to AP relationships as well as to the transverse relationships. So there was a big push to see if we could orthopedically correct children, young children, so that we can modify their growth. And the process that we utilize in the 50s to the 90s or functional appliances. We thought that if we change the we could change the relationship of the jaws by using external forces and by using dental mechanics. And our hope was to modify class 2 and class 3 relationships into class 1 relationships. We experimented with mixed results. And we found that sometimes we could affect skeletal change, but often we couldn't. And when we use the scientific approaches to determine if we were successful in the early 2000s and the late 90s, the big randomized control trials for class 2 correction, predominantly using twin block type appliances through O'Brien in the UK and Profit in the US. The results were unfortunately very disappointing. Changes appeared to be present immediately after these functional approaches were carried out, but seemed to fade away once phase 2 treatment had begun in the teenage years. And the definitive outcome of these randomized controlled trials seemed to show that two-phase treatment, which is growth modification in the early childhood, followed by fixed braces in the teen years, didn't really show any difference to just one phase of treatment in the teenage years. And that the long-term outcomes of treatment that were started in the early years effectively made no skeletal-based changes. There were dental improvements, dental relationship improvements, but the cephalometrics that they evaluated didn't really show real skeletal changes. So from the 2000 onwards, our profession deemed orthopedic changes to not be possible in a predictable manner, and that two phases of treatment, early intervention combined with teenage intervention, rarely improved the situation, so was deemed an unnecessary treatment. So early intervention has, over the last 20 years, been phased out. The current focus is using TADs, so temporary anchorage devices, higher into the basal bone or lower into the basal bone if it's the mandible, and kind of en masse moving the whole dental arches because of the absolute anchorage provided by the TADs. That, combined with more advanced surgical approaches, seems to be the method of choice in today's orthodontics. Equally, there was interest over many decades on whether orthodontic approaches affected TMD health. or airway health. And none of the approaches that have been used or studied seems to impact temporal mandibular joint health and airway health. So based on the evaluations and the studies that were carried out, we found that the approaches that we have used to date don't seem to be particularly effective in changing skeletal relationships, temporal mandibular dysfunction, nor in airway health. So based on the current research outcomes, dentists' influence are predominantly in the dental alveolar complex. So when we claim to be able to affect temporal mandibular health, airway health, and skeletal growth, unfortunately, we have no techniques that have been researched well enough to definitively say that what we as dentists can do can predictably change the outcome of those three parameters. So it is fair to say that dentists are basically oral health specialists and have no real impact on the larger medical health of the patient. What we're trying to figure out, however, is to understand why we don't influence things that theoretically, logically, we should be able to influence. And I think one of the few people who've been able to discover how there's a link between growth to posture has been people, orthodontists and surgeons like John Mew and Wilfred Engeckel, the ENT surgeon, who have worked out that posture, oral posture, has a significant impact on jaw growth and airway health. And as a side note, temporal mandibular joint health, because it's all intertwined. Why have we not been successful in the past in any of those endeavors? We have latched onto the concept of function and not really paid attention to the concept of posture. And we know that all our interventions have been based on using functional approaches, that are determined by what happens when we open our mouth. How do we pull the maxilla back using mechanics to meet the mandible when we open the mouth? Because that's functional appliances tend to work or be activated when we're opening. And the maxilla, when we're opening the mandible away from the maxilla. Whereas posture theoretically operates to the betterment of growth when we are closing or when we stay closed. Right? One focuses on the opening and closing action, and one focuses on the closed position when we're still. So we really haven't focused any attention on the closed position or the resting posture, but we focus a lot of attention on the actions of opening and closing in function. And I think physiological and biological reality is that growth isn't change in function, which is high impact, short burst activity, but growth can be modified and is influenced in long, steady, light forces. So this is a concept that Prophet proposed many, many decades ago in the 70s, the equilibrium theory. And it effectively states that, our bodies move in space when we apply heavy, light, and short forces, but our bodies adapt to light, continuous forces. And so the human nature of being infinitely impatient, we latched onto functional approaches where we utilize movement to help make growth changes without remembering the concepts of basic science. Now, why would we still advocate expanding early rather than late? If our approach is a unilateral approach where we are only expanding the maxilla, then it actually doesn't really matter whether you expand in early childhood or in late childhood. In postural orthodontics, our approach is we treat early, we expand the maxilla, but we also expand the mandibular arch. And that combination allows us to coordinate the arches so that we can improve the posture, because you can only improve the posture when you have a nice bite relationship. When you just expand the maxilla, you wreck the bite, and it is inherently unstable. So whether you do it in early childhood or late childhood, it doesn't really matter. It's unstable on both sides. In postural orthodontics, where we expand the maxilla, but we combine it with mandibular arch expansion, then making space and correcting the bite relationship simultaneously is beneficial, because mandibular arch expansion is very difficult, if not impossible, in the late childhood, because you can't expand the basal bone of the mandible. But in early childhood, the dental alveolar component of the mandible is very vertically extensive, because you're not only expanding the mandibular arch, but with the stage 1 appliances that extend into the sulcus, the deeper down into the arch form, you're developing the dental alveolar component that houses the permanent tooth buds. So your ability to develop laterally in the younger child, in the mandible, is present, but it's dwindles as the child gets older. So teenagers in the second decade of life, very hard to expand the mandibular arch. Children under the age of 10, it's very easy to expand the mandibular arch. So if you want to affect real change, you can't just treat one arch unless it's a class 3. But most of the people we treat are class 2. So we want to treat early because we can effectively get a much larger mandibular arch if we treat in the first decade. And that's why we advocate for early intervention. Changing the posture changes the tongue relationship in the oral cavity and in the pharyngeal space. If we want to affect an airway change, then we have to understand Engeckel's physiologic rest protective posture, where if the tongue is suctioned to the palate, then it won't fall back into the airway. But you can't create a good physiologic swallow unless you're in a class 1 relationship. So if you can affect the change in both arches and you can change the resting posture, then you can help with the airway. That said, that's not what our license extends to. Right? We're not here to change airway health. Understanding that means we can't claim that we can because it's not part of our license. So we might improve, we might not, but it's not our focus. Our focus is on improving growth, improving the relationship of the maxilla and the mandible, and that primarily requires an improvement on the posture. And if we understand physiology, then that will also improve airway health. But our focus is on orthodontic growth and development. We may or may not improve airway health, but we can't lead with something that we don't have a license to treat. All right, that's all we have for today. We've gone over time. We'll add the last question to next week's exciting adventures. All right, so that's it. Thanks so much.